on this episode of A Tale of Two Hygienists.
Younger people who, let's say, use a lot of cannabis, use a lot of stimulants like energy drinks, that kind of thing, could easily have the same amount of or the same type of xerostomia as a person who takes xerostomic medications, and yet we wouldn't necessarily look at them as someone who has xerostomia because we wouldn't suspect it based on their age. So I think we have to remove that sort of age bias, if you will, and say, okay, it could be anyone with dry mouth, and they all deserve to be treated. Water just doesn't cut it when you're trying to rehydrate the oral tissues and keep moisture, retain moisture in the mouth. So that's why lipid-based products seem to work better because they work better because they, number one, coat the mouth, they provide that protective coating, and number two, just like anybody who's ever used moisturizer after showering, it locks the moisture in and prevents it from leaving.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Happy Saturday, everyone, and welcome to a special bonus episode of A Tale of Two Hygienists, brought to you in part by A Quarrel. I'm your host, Andrew Johnston, and thank you for joining us today. So, here are the two big things that this episode has for all of you. One, real advice about our patients experiencing dry mouth. And two, one of the best speakers that you all tell me that you love so much in Tom Viola. I love him too. He's great. It's an incredible episode. And I guess what I'm hoping is going to happen is that this is going to change how your thinking pattern is about dry mouth. It's not a has dry mouth or doesn't have dry mouth. It's a spectrum. And when people have more than just a little bit of symptoms, how do we change our protocols? And that's what we're going to talk about today. And Tom does a wonderful job in discussing that. I have a ton of information also in the show notes. So please click into the show notes and reach out if you have any questions whatsoever. I'm also trying something a little bit new with pasting a QR code in the show notes. I'm not sure if it's going to work really well, but if you like that format, please let me know, Andrew at A Tale of Two Hygienists, and I will keep adding them for all the episodes that makes sense for. So thanks again to Tom and also the team over at A Quarrel. I hope you enjoy this episode and enjoy your weekend.
A tale of two hygienists.
All right, everyone, welcome into the interview portion. I am joined by Tom Viola again. You know what I like about this, Tom, is you and I have had so many opportunities to do podcasting again, and it feels like old times.
We have, and it does feel like old times. I enjoy it. Sometimes I don't really understand it's like my voice. I don't sound like that in my head, but
I would love to have like a whole bigger conversation on that because you are absolutely right. I'm like, I actually sound good in my head, but when I listen to myself, I'm all nasally and like,
me too.
I'm like, dude, blow your nose a little bit. I'm just like, dang it. So welcome back to the podcast, man.
Well, thank you, buddy. I look forward to it every time. It's a pleasure being with you. You and I are like two kindred spirits. We think the same. We talk the same. So it's just, it's easy with you, buddy. I appreciate it.
We've gotten a lot of really good feedback from the Fast Facts segments that you've been doing. We have an expansion that we're going to be doing on the same topic we're talking today about with dry mouth. So Everyone can look forward to those ones coming forward soon. But, we got a lot. The last one that we did on local anesthesia with Misty Mattingly. Do you remember that? In Orlando.
Orlando, yep.
That had some of the best feedback that I've had in a long time.
Awesome.
And you know what? Like, listeners are here for you. So
wow,
this is going to be great. Okay.
I'm a lucky man.
Listeners, here's the thing that we see in our practices, right? We see this thing, xerostomia, this dry mouth issue. So we are hoping to have Tom on today so that we could, address some of the things that he knows, that he's seeing, some of the things that the clinicians are seeing. Hopefully we're going to be answering some of your questions that you have in your own head about this. But I'm imploring you right now, Tom is at your disposal. If you want to, please reach out to him and ask him for follow-up questions on this thing.
Absolutely.
Well, should we jump into it, Tom?
Let's do it, buddy.
Okay, so dry mouth. Let's talk about prevalence, because I feel like that's a good place to start. Where are we at with the prevalence?
Well, I've heard various numbers thrown about as far as how prevalent dry mouth is. Some people say 10%. I think it's probably more than that. It may very well be closer to 20%. which is a big number when you think about the number of people in the United States. We're talking about millions of people with dry mouth. And of course, in my experience as both the pharmacist and the pharmacologist in dentistry, it's not uncommon to see the more people getting dry mouth as they get older. So
Sure.
over the age of 55, you could even think maybe the prevalence is something around 30 to 35%.
Yeah. That makes a lot of sense. Do you feel like it's on the rise?
Well, I will say it's not always just something you see in older patients, though. We tend to think dry mouth is an older patient syndrome because older patients tend to have more disease states and tend to take more medications to treat those disease states. So if you think, okay, disease states can cause dry mouth, medications can cause dry mouth. If you've got a lot of disease states that are occurring concomitantly and you're taking a lot of medications that can cause dry mouth concomitantly, that's a lot of dry mouth. So
Sure.
I can see how an older person might have that. But let's not forget that younger people, where, again, we may not be ready for this, younger people who, let's say, use a lot of cannabis, use a lot of stimulants like energy drinks, that kind of thing, could easily have the same amount of or the same type of xerostomia as a person who takes xerostomic medications. And yet we wouldn't necessarily look at them as someone who has xerostomia because we wouldn't suspect it based on their age. So I think we have to remove that sort of age bias, if you will, and say, okay, it could be anyone with dry mouth and they all deserve to be treated. My concern with younger folks is you got a lot more runway ahead of you in your life to hold on to your teeth. So you need to get that treated if you're younger with xerostomia earlier on to maintain your teeth the rest of your life.
I was listening to a podcast on the plane here, and so I want to speculate just a little bit, and you correct me when I'm telling lies to our beloved listeners.
You got it.
So, this was, you'd actually done, I think you did a podcast with Kevin Henry
Yes.
on Wegovy and some of these weight loss drugs.
Yes,
I believe that was you.
Yeah, it was. It
I
was
was
me.
hoping it's you. Okay, so this episode that I was listening to was on this as well, and they had some scientists that got on. Some were for, some were against, right? And they were talking about kind of like the history of the world and how, the whole hunter-gatherer thing, blah, 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 blah. And then you get through, and then you look back even just to the 50s, which probably for people born in the 2000s, that sounds like a long time ago, but for me, it doesn't sound like that long ago, right?
Yep, exactly.
I'm like, okay, the 50s were a different time, right?
Yeah.
Our food supply, our food, the food chain was different. And now, we have so many refined everything, so many sugar-laden everythings. And what they were talking about is because of these changes, people and their behaviors and their mental health and all these other things are also changing.
Yes.
Which is increasing the amount of medications that we're using to combat these issues, right?
Right.
And I'm not saying go on paleo, you're going to be fixed. Like, that's not what I'm trying to say. But, we are a different breed now than we ever have. And so you look at young children, you talked about the age thing, ADD, ADHD, like we have medications that we use for that we wouldn't have probably had decades and decades ago. The Wegovy thing is a brand new thing.
Right. If there was a need for those medications back then, because maybe all of these refined sugars, refining, processing foods, ultra-processed foods, maybe they create this imbalance, which a lot of people have said occurs in the flora, the microflora, in our gut, and in other parts of our body, which can alter our ability to absorb nutrients, can alter our way of thinking, and just the rise and fall of our blood sugars can even be problematic in the way we process thoughts and ideas. So, I'd say we don't have the ability to do it, but we can go back in time and see what it was like to really live in the 50s and see what difference our nutrition has made on us psychologically and physically. I think there's a lot of truth to that, in my opinion, because I think it has to have an effect somehow.
Yeah. And I would imagine dry mouth for a 20-year-old in the 50s is going to be way different than dry mouth for a 20-year-old now.
Absolutely.
I mean, cannabis you mentioned. I mean, there's some other things. What are some of the other kids doing nowadays? Vaping, I guess, would probably maybe contribute to that.
So vaping, whether it includes cannabis or not, definitely can cause a xerostomia, as well as oxidative stress on the respiratory system. You've got these energy drinks that are high in caffeine, high in sucrose, You've got sports drinks that are also high. I mean, we keep pushing electrolytes saying, well, we're athletic and we should all be drinking, sports drinks.
Yeah.
But some people really don't need a sports drink unless they're truly depleted and they've really been doing some high-intensity workout.
Yeah.
So, again, you've got all of those things. Plus, you've got the fact that smoking still exists.
Yeah.
So nicotine is still there and always will be there, omnipresent as a potential problem for us. So again, I'd like to say it's the older people that we look at, older patients, and say, well, they're likely to have xerostomia, but it's the younger people using multiple products like we just described. In a way, just like older patients use multiple medications, younger people use multiple products, that they too then could develop xerostomia. And then, like you said, let's not discount things like ADHD medications, right? Which they use, which they're prescribed. And overall, I think you can see that xerostomia has no age limit. There is no one type of person with xerostomia.
Absolutely. Let me ask you this. One of the things I love about what you do is like you talk to all, like the hygienists love you. Like we still claim you as one of ours.
Yep.
But you speak to all dental professionals. So you have a bigger picture, I think, than a lot of people do see. How imperative is the role of the dental hygienist in identifying dry mouth?
It's huge. It's probably the one, I've said this in so many lectures, I think people could probably recite it before I say it. That the role of the dental hygienist in maintaining not just oral health, but systemic health is huge, because it's the hygienist that sees the symptoms of systemic disease and oral disease before the patient even sees it themselves. So you've got, I can see the obvious signs of GERD. I can see the obvious signs of potentially, the ramifications of using cannabis, of vaping, and so on. So I see systemic disease, but I also see oral disease. And a lot of walk around with xerostomia and don't think they have it. They become so accustomed to having a dry mouth that they just think that's their normal thing. My mouth is always dry. And then they don't make the connection between xerostomia and or dry mouth with decay, with caries, with the potential for losing their teeth. What's so bad about having a dry mouth? I take a swish of water and I'm good. But it's what happens at night when you're sleeping. It's what happens if you tend to be more of a mouth breather and don't realize it. So you're losing the protective effects of saliva, and your teeth will pay the price for it ultimately. So the other problem, though, is, and I've said this many times, people have a hard time deciphering, including us, is it a dry mouth or is it dry mouth? Is it true salivary gland?
No, don't slow down. Let's say that again.
Right. So is it a dry mouth or is it dry mouth?
Love it.
Is it true salivary gland hypofunction? Or is it a subjective sensation of not having enough water or saliva in your mouth?
I want to come back to something you said earlier about like the patients not really understanding how bad it is, they're normal, et cetera. But I really just quickly, I would love for you to list off a few things, top reasons why people have dry mouth, in addition to what you had said earlier.
Okay, so reasons why people have dry mouth. I would say, first of all, it could be a disease like Sjogren's disease, right? Certainly, right? Head and neck cancer, obviously, the effect on salivary glands. And along with that, I would say chemotherapy and radiation, because that's again, every time you irradiate the salivary glands, you're damaging them to the point where they don't produce saliva.
And honestly, that's like one of our, in clinic, that was the first thing that we look for if someone has had that report on their medical dental history. Say, dry mouth.
Exactly.
Yeah.
And then I'm going to have to say medications. I don't like to say medications because everyone says xerostomia is medication-induced or drug-induced. But let's face it, people take more medications now that are xerostomic than they ever did before. We're talking about antidepressants, antipsychotics, even antihistamines. All can cause dry mouth because people use them on a much more regular basis than ever, especially post-pandemic. There's a lot of mental illness, and people take medications to treat those illnesses. Diabetes, obviously, you've got a high carbohydrate load. That's hyperosmotic. That's pulling water out of your mouth, right? And again, things like we talked about, sleep apnea, using a CPAP machine, me being a mouth breather. And then there are, I like to say, diseases that cause xerostomia, things like Alzheimer's and other neurodegenerative diseases, even things like systemic lupus erythematosus, all of that. And then you've got to add the lifestyle stuff in. You got to add in tobacco usage, cannabis usage, alcohol use. So those are the things that I see most in patients who are looking for some treatment for xerostomia.
You kind of touched on this a minute ago about cannabis use and just the I guess bigger category of lifestyle choices.
Right.
Do you feel like that's this might be too subjective, and that's okay, but do you feel like that is the biggest gain in xerostomic effects, or is the bigger gain, you think, in like the medication induced or whatever the right way of saying that is?
So I think if you asked me prior to the last 5 years, I would have said it's much more quote unquote medication induced. After the last 5 years, I would say cannabis has become a medication.
Oh yeah.
So
Okay.
people self-medicate with cannabis. And the problem with cannabis is it does cause xerostomia, certainly. But people don't realize how much xerostomia it can cause, that it can cause tachycardia and hypertension as well. Cannabis has other effects beyond just what people think are the medicinal purposes. Now,
Sure.
realize the cannabis industry is fragmenting now. It used to be that you used cannabis to get high and also maybe treat disease. But now you're seeing the introduction of some minor cannabinoids like CBN and CBG, which are being used to treat disease and not get high. But that doesn't mean that those minor cannabinoids don't cause hyposalivation, because they do, and it can
Sure.
easily cause xerostomia. So to answer your question in a long way around it, I think it's mostly because of cannabis use increasing over the course of time to treat medical symptoms of medical conditions, that you're seeing a widespread use of cannabis. And I'm going to be honest with you, Andrew, because, this is where I see the industry going. Because I think cannabis use and xerostomia in young people and older people will be inexorably tied together. Let's be honest. Right now, people are willing to use cannabis if it makes them smell like skunk. They're still willing to use it, okay? Now, with
Yeah.
the way the industry's going, and terpenes and flavonoids and genetic modifications of the plant itself, if someday soon I can make cannabis smell like lavender or taste like butterscotch, I think you and I could agree.
Basically, what vaping has done,
Right.
All
And
those
so,
flavors,
right?
yeah,
So think Juul, right?
yeah,
So that's the one-word answer, right? Would say, I don't believe that, Viola. Believe it, because when the genetic modifications take place and we start altering the plant even more to make it more palatable, more flavorful, more scented in ways that we find pleasing, there's going to be a lot more people using cannabis.
Yeah.
So we've all got to be ready for that. And it starts with the hygienist, because if I had a dry mouth and my hygienist says, look, I'm starting to see signs of decay, is your mouth always dry? That's the person I'm going to talk to more than
Sure.
anybody else.
yeah. No, absolutely. It's funny talking about cannabis. We're in Chicago. Every corner you can just smell the skunk smell. You're exactly right on that one.
Yes.
And I did see a study. This is probably just adding more onto the layers of it. I saw several write-ups about the studies of the younger generation, the 20 to 30-year-olds of today, are drinking much less, right? They're going away from alcohol and moving into other types of things like cannabis as kind of their choice. And that's an interesting, I think, shift in mentality of the patient that we're going to be seeing. This is a weird aside. So let's go back to we're talking about the patient, and they're just oh, this is my normal. Do patients know how bad their dry mouth is?
That's the thing. They don't realize how important it is to understand that their dry mouth is not just simple dry mouth, because of their concomitant use of both substances and maybe medications if they're younger, or all other medications and over-the-counter drugs when they're older. They don't realize how serious their dry mouth is until it's a little too late. And that's where the hygienist makes the greatest difference, because it's not a mild case of xerostomia. It's a moderate to severe case. Now, what do you do to treat it? I can tell you almost every person I've ever asked this question says, oh, just use a mouth rinse. Just use a rinse and rinse your mouth out and you'll be fine.
Well, that's what they have in the cancer wards, right? They're saying, okay, these are the things over the counter or whatever. Yeah.
Absolutely. But see, my problem with that is that almost every one of those mouth rinses is water-based. And water just doesn't cut it when you're trying to rehydrate the oral tissues and keep moisture, retain moisture in the mouth. So that's why lipid-based products seem to work better, because they work better because they, number one, coat the mouth. They provide that protective coating. And number two, just like anybody who's ever used moisturizer after showering, it locks the moisture in and prevents it from leaving. And because of the lubricity, because it has that lubricant effect to it, it's easier swallowing. And that's what I wanted to get into, Andrew, because I'm going to turn the tables on you. How about that? I'm going to ask you the question now.
As long as I don't have to say what lubricity is, that's fine. Go ahead.
You're the expert, okay? You're the clinician, so I'm going to ask you.
Yeah.
When it comes to product selection, so some of the things that people are concerned about, obviously, are availability, pH, and so on. But bottom line is, if you're going to pick a product, what matters most, do you think, to the patient? when it comes to, okay, I got to use this product not once in a while when I feel I have a dry mouth. I have to use it every day. What counts? What really matters if you're going to pick a product for that?
Can I answer it very complicatedly?
Sure, please.
Okay. At the beginning of my career, right? You asked me, what does a patient want? And I'm like, you know what? They just want to get in and out of my chair as fast as they can get, right?
Absolutely.
Logically, that kind of doesn't make sense.
None.
Right? Okay. So then as time goes on, camera was introduced to me, several perio assessment, protocols were introduced to me. We have these ability to take objective data, explain it to the patient, and show them the same objective data, and then make maybe even a more complicated treatment plan, if we have to, that they're more willing to accept, and they're going to be happy about it. Oral cancer screenings is another example of this, right?
Right.
It goes from the quick little, okay, you're fine, to now using devices and things like that. If you explain it to the patient, if you help them understand, I think the patient really wants what's going to be effective.
Correct.
They're going to want what's going to really work for them.
Agreed.
Availability is important, right? I think, but you as a provider, if you believe in it, if you understand the science, if you understand why it's better than something else, you make that prescription to them, not recommendation, prescription to them.
Yep.
They're going to feel good about it, and they're going to do it. That's my opinion.
I agree.
It's kind of a complicated answer, but it's like,
no, I agree. 100%.
Listeners are at all different stages in their life, right? In their career. And so like, I just think that you just have to figure out where you're at, and you're going to agree. Like, some people are going to be like, Andrew, heck yes, that's exactly right. And the other people are like, my patients don't want that. I'm like, oh, okay, whatever.
Well, and you said it right. I couldn't have said it any better, my friend. But, the other aspect of that as well is it convenient to use? If I'm going to use a rinse, am I going to carry around a bottle of rinse with me? And let's say I do rinse. Obviously, I can't swallow it. Where am I going to spit this out? I'll just spit it out on the street. I mean, what if I'm in a building, in a meeting? Like, I need something that's not only going to work, like you said, effective, but I need something that's going to be convenient to use. And I dare say discreet. Like, okay, no one even really noticed me using this. And so, for example, the Coral spray that's available, it is a prescription drug. Certainly, dentists have to prescribe it. But one of the reasons why I love a Coral so much is because it ties together all those things. It's OGT technology, so it's like the easiest way to describe it is sort of like corn oil, right? So it's an oil-based or lipid-based product, and it's a spray. It's a very small spray that you can easily fit in your pocket. So you pull this thing out, right? You spray it in your mouth. It provides instant relief. It coats your mouth. If you've taken a swig of water before then, now it's locking that moisture in. The spray goes back in your pocket. It's completely discreet. There's no rinsing. There's no mixing. There's no spitting. I mean, honestly, it's a home run when it comes to treating xerostomia when you're a busy professional, or when you're someone who just, is working at their job every day and can't take the time out to go into the restroom and use a rinse.
And honestly, to me, it's not all that uncommon. Banaka. You remember Banaka?
Yeah, Banaka, absolutely.
You were cool if you had a spray, right? Like it was like,
yes, sir.
Not a lot of people had it. Some people had the gum, the mints, and all that kind of stuff. But if you had a spray, you're like,
yep,
then
you were awesome.
You're so awesome. And so, I mean, look, let's bring that back. Let's normalize that again. You're cool if you have a spray.
Yep.
That's your tagline, a Coral. Just heads up. We're changing your tagline. Oh, my goodness.
I agree.
But you're right, though. I mean, the convenience factor of it has to be.
Well, and that's why I want hygienists to know about it, because if you're a hygienist right now, everything you just heard us say makes a lot of sense to you. And now you're saying, okay, what am I going to do to help my patients? What kind of product recommendation am I going to make? It's always been the same. And I don't have to mention the names to you. I'm sure you know all the different rinses that have been available out there. But there have been other things, Xylamelts and gums and, all those things. So there's biotin, there's Xylamelts, there's all these different products out there. And I'm not saying they're not good products. I'm just saying when it comes to effectiveness and convenience, you've got to pick a product as a hygienist that's going to work for your patient. Otherwise, they're not going to use it. And then it doesn't matter anyway. So give them a product that they can use that would make it easy for them to use it, make them easy to be compliant with it. And I think ultimately that's going to make them happy. Let's not also forget the other side of this, Andrew. And I wanted to pick your brain on this too. we keep talking about xerostomia. We talk about it from our perspective. Yes, we know about decay. Yes, we know about, damage to our teeth. But we don't focus necessarily on what it matters to the quality of life for the patient. If there's not enough saliva in your mouth, first of all, you can't chew very well because you can't moisten your food enough to chew it, right?
Right.
And that means if you can't chew your food well enough, you can't swallow it, again, because it's too dry, it's not moistened enough. So now you try to force this bolus of food down your throat, which could easily cause esophageal damage as well as aspiration and choking. And then, remember that saliva has enzymes in it that help digestion. So now you're getting indigestion, not digesting your food as well. And again, if you can't eat very well, if you can't eat cleanly, if because of the fact that there's not enough saliva in your mouth, your food particles are flying out of your mouth when you're eating and, you're gasping and choking, guess what? You're not going to do that in front of other people.
Right.
So now you're isolated. Now you don't eat in front of other people. You eat by yourself. You don't go out to lunches with your friends or dinners with your friends because you don't want to eat because it's embarrassing to you. So you tend to become more isolated. Then what happens? Then, you can't speak very well. You can't form the words very well because the mucosa in your mouth is sticking to your teeth and you can't get the words out right. So guess what happens? You don't talk to anybody anymore. And again, now more social isolation. So ultimately, it's not just dry mouth and an effect on the teeth. It's dry mouth affecting your overall quality of life. And a product like a coral, as discreet and simple as it is to use and effective as it is, can make all the difference and turn that all around.
It's simple. It's not that hard. We just have to have the right thing. Right? So it's a key, right?
Exactly.
There's a lock. We have a key.
We got a key. And the hygienists hold the key. So if hygienists that are listening, again, if you want to give a coral a try for your patients, feel free to check out the link. I'm sure we'll have that somewhere in the notes or whatever. But this is a prescription drug, so your doc's going to have to prescribe it. Folks at a coral make it really easy to prescribe. And I just think they're probably one of the best products we've seen in a long time when it comes to the dry mouth category.
Well, I'm really excited about it. And yeah, listeners, we absolutely have it in our show notes. Make sure you look it there. It's everywhere, right? You could just simply Google it. You'll find it as well. Tom is available for any follow-up questions you might have. I'll have his contact information, of course, in the show notes as well. Tom, thanks again for being here. You're just a wealth of knowledge. We're very lucky to have you serving our dental profession, and we appreciate it.
Now, you know how many times I've said this to you. I'm going to keep saying it until you tell me you've heard it too many times. I appreciate everything you, Andrew Johnson, have done for the practice of hygiene. You've done amazing things for this profession. Someday, I hope to see you as president of ADHA. How about that? That would be awesome. Can we
make it executive director and you have a deal?
All right, done. ED. That's what. Wait a minute. We can't use those initials. ED.
It's a different kind of.
But yes, I hope someday. Yes, my friend. And thank you for all you do. Seriously, you're a great guy, and it's always a pleasure working with you. And you just make this a lot, of fun. So thank you, my
friend. You're too kind.
Thank you, sir.
All right, listeners, have a great weekend.
Thanks, everybody.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.